This visualization contrasts two realities of laparoscopic ventral hernia repair. Left, surgical site infections drop to 1.1%. Right, mortality for missed bowel injuries is 100%. Avoiding surface morbidity shifts risks deeper, forcing surgeons into high-stakes internal environments where technical errors are highly consequential. Complications in LIVHR, from bowel injury to fascial dehiscence, the splitting of the surgical wound, result from specific violations of tissue planes or failures in the biomechanical management of the abdominal wall. This diagram maps the abdominal wall surgical planes. Primary areas are the intraperitoneal space for IPOM and the extraperitoneal retrorectus planes for ETAP. Every intervention follows three distinct phases: gaining access, dissecting the anatomical planes, and integrating the synthetic mesh. The clinical decision matrix provides a standardized response to interoperative crises within these stages, converting unpredictable accidents into manageable, repeatable algorithms. Technical skill is secondary to the algorithmic discipline required to navigate these high-stakes anatomical planes safely. The first operational phase, access and adhesiolysis, presents the highest leverage risks. Adhesiolysis is the surgical process of separating internal organs that have become stuck together or to the abdominal wall by scar tissue. Bowel injuries occur in 6 to 14.3% of cases. In 92% of these instances, the injury involves the small bowel, which is often tethered to the site of the hernia. This footage shows an iatrogenic injury occurring as the surgical dissector separates dense adhesions and inadvertently tears the tissue, breaching the bowel wall. The contamination decision tree is the first major branch of the clinical matrix. Once an injury is identified, the field is categorized into one of three paths: no spillage, doubtful contamination, or gross spillage. In the no spillage protocol, the surgeon repairs the bowel laparoscopically and proceeds with mesh placement. It is preferable to place the mesh in the retrorectus plane to isolate it from the repaired bowel. For doubtful contamination, the injury is repaired, but the hernia repair is deferred. A staged mesh placement is planned for several weeks later once the risk of infection has subsided. Under the gross spillage protocol, the surgeon performs an intracorporeal suture repair of the bowel, suturing inside the body, and abandons the synthetic mesh entirely to avoid a guaranteed infection of the prosthesis. Biological mesh is rarely a standard alternative here. These meshes carry higher recurrence rates and significantly higher costs compared to synthetic materials. Instructive. Following any injury or difficult dissection, the surgeon must perform a systematic bowel walk. This involves tracing the entire length of the intestine to identify missed rents or thermal injuries caused by energy devices that could lead to delayed leaks. Bowel repair requires tension-free, interrupted sutures. These must include both the submucosa, the dense layer of connective tissue, and the serosa, the outermost layer of the bowel. This contamination matrix replaces subjective intuition with a data-driven protocol that prioritizes patient survival over immediate hernia closure. We move to the second phase, dissection and plane creation, with a focus on the extraperitoneal space used in ETAP. While seromas and hematomas, fluid or blood collections, are common and manageable, ETAP carries the risk of mechanically catastrophic PRS dehiscence. The PRS, or posterior rectus sheath, is the deep layer of fascia that lines the back of the abdominal muscles. PRS rupture is a biomechanical failure. When the sheath is sutured longitudinally, lateral tension from the abdominal muscles pulls directly against the stitches. The pressure of surgical pneumoperitoneum and postoperative coughing provides the final force to pull the tissue apart. Transverse suturing, stitching across the width of the defect, resists these natural distracting forces by distributing the load across the suture line. Precise management of the crossover step is equally critical. This is the moment in ETAP where the surgeon moves from one side of the abdominal wall to the other. Cautionary: excessive medial dissection during this step can injure the linea alba, the central fibrous line of the abdomen. Damaging this structure destabilizes the entire midline, leading to asymmetric fascial closure and a potential blowout of the repair. PRS dehiscence typically presents as early postoperative bowel obstruction. Bowel loops become trapped in the space between the muscle layer and the ruptured posterior sheath. This requires immediate surgical exploration. An IPOM repair serves as the necessary salvage surgery if the primary extraperitoneal repair suffers a total fascial rupture. The durability of an ETEP reconstruction depends on the surgeon's ability to accurately manage internal tension vectors. The final operational phase is mesh integration and the elimination of dead space. This diagram illustrates the failure of bridging repairs. The hernia defect is left open and patched with mesh, leaving an anatomical void known as dead space. This space acts as a reservoir for fluid, causing a seroma and a visible postoperative bulge. The IPOM Plus protocol prevents this through mandatory primary closure of the defect before mesh placement. Closing the fascia ensures a strong tissue-to-mesh interface and eliminates the reservoir for fluid. Proper integration is also the best defense against mesh infection. If a PTFE mesh, a synthetic polymer called polytetrafluoroethylene, becomes contaminated, it requires complete surgical excision. Abscesses and fistulas will persist as long as the infected material remains in the body. Modern integration requires active fascial closure to ensure long-term biomechanical stability. Bridging is no longer an acceptable standard. This map connects the enterotomy matrix, the ETEP tension rules, and the IPOM Plus closure protocols into a single, unified flowchart. Fading the failure pathways reveals the optimized pathway, the specific algorithmic steps required for a successful repair. Successful outcomes rely on recognizing an error the second it occurs and instantly deploying the correct, standardized response from the matrix. The surgeon acts as an anatomical navigator, rigidly respecting the borders of tissue planes as robotic and extraperitoneal techniques continue to evolve. Complications in LIVHR are predictable biomechanical events that can be neutralized through algorithmic discipline. Mastering the topography of failure ensures that the clinical decision matrix remains the ultimate tool for patient safety and surgical durability.